Like it's 9 o'clock. So we're going to go ahead and get started. Good morning, everyone. My name is Allison Jackson, and I'm the Chief of the Child and Adolescent Protection Center here at Children's National. And I thank you for joining our second presentation for this Child Abuse Awareness Educational Series that started earlier this week. And so I thought that this would be a good time for us to talk a little bit about secondary trauma and compassion fatigue, which I think is certainly heightened at the present moment and may take on even a new face in the context of this pandemic. So let's start with our learning objectives, if I can advance the slide here. And actually, this is going to be a little interactive, if at all possible. So for those of you who have your cell phones nearby, if you wouldn't mind getting your devices ready. So you would text, the number that you're texting to is 22333, and the message is Allison Jax 509. And those instructions will come up again as we move on. So if you don't get a chance to do it right now, there'll be another opportunity to see how to participate in the interactive polls. I'm going to have you watch a little video, and we tested this, so this should definitely work. Or not, all of a sudden. Wow. How about that? What works yesterday doesn't work today. Okay, well, I'm not going to belabor that. And apologies for the technical issue that didn't happen yesterday. The point of the video, though, in somewhat a lighthearted way, is that in our day-to-day activities and our professional roles as people in a helping profession, whether you are working at the front desk, registering patients, whether you're a radiology tech, a nurse, or provider, or anyone in between, whether you're cleaning the room of a patient, we are affected by the experiences of the children and families that we serve. And this is just a kind of lighthearted video describing kind of how at the end of the day, we may not feel like much of anything after kind of pouring out all day or hearing or being exposed to these things. So our objectives for this morning are that you will know the difference between burnout, vicarious trauma and compassion fatigue, and secondary trauma, and that you will be able to recognize the signs of burnout and secondary trauma and identify some strategies to promote your own personal well-being and the well-being of your coworkers and colleagues. So I wanted to just start out with kind of a definition of trauma. And I think in a hospital setting, when we think of trauma, we are thinking of really this, the physical trauma, the injury caused by something external, some event. But it can also be emotional trauma, and can result in kind of emotional stress or mental stress. So this is the American Psychiatric Association's definition of trauma, and that is exposure to actual or threatened death, serious injury, or sexual violence. And that may be direct experience of that event or those events, witnessing something that happens to someone else, or hearing about what has happened to someone else. Which I think really makes us, it certainly makes me pause to think about, yes, while we may not see the events that have occurred, we certainly see the child, the injuries, or hear their disclosures, or work with these families or children who have experienced traumatic events. And so we too experience trauma. As a child abuse pediatrician, I'm going to kind of take the liberty to give the perspective from through the lens of a child abuse pediatrician, recognizing that there are other professionals or folk who have other areas of practice that may also experience some of the same or similar things. This is a survey in Canada. 165 child abuse or child welfare professionals. And it was a survey really about burnout and kind of the emotional effects of their work. And pretty high response rate for the small number of participants. And about a third of them exhibited burnout. About a quarter high emotional exhaustion, which transitioned or translated to cynicism or low professional efficacy. A smaller percentage exhibited psychological morbidity. And interestingly, almost 70% reported high job satisfaction. So it's a quite maybe unexpected distribution of responses from the participants in this study. Just as many who reported high job satisfaction about also contemplating doing something else. So also interesting that, you know, folk love their job, but they certainly also sometimes wonder, is there something else I could be doing? So, you know, I've been a child abuse pediatrician now for almost 20 years. And I'd say early in my career, this particular topic was nowhere on my radar. I hadn't heard about it, didn't know it existed, didn't know what it was. And then I had this patient. And this was a little girl who escaped from her home to a neighbor and was ultimately transferred from an outside hospital here. And she had extensive injuries that were the result of abuse by her adoptive mother. Here's just a depiction of some of what I saw on her exam. And in talking with her, she's just an amazing little girl who had the agency to get out to, as she said, really save herself from being killed. And so, you know, I saw these marks on her leg, and I don't know if you can appreciate them. I've circled them. They look like little check marks, and I had no idea what those were from, but it certainly was a repetitive pattern. I hadn't seen that particular pattern before. And I asked her what they were from, and she said, well, if you look in the closet, you'll find a shoe with blood in it. So lo and behold, the detectives did find a shoe in the closet with blood in it, and the heel of the shoe is what caused these particular injuries. And I have to say, this particular case was one of those cases where when I came home that night, this was the first time that I had a conversation with my husband about, you know, well, maybe we could adopt her. And he immediately looked at me and was like, no, stay in your lane, which is a good thing. But I also remember after having seen her and, in the process of writing up my note, called the detective to give the detective an update on my findings. And I'll never forget the tone of his voice. He seemed upset, and he said to me, I don't know if I'm supposed to say this to you. I don't know if I should be telling you this, but we just found her sisters in the freezer. And so this ended up being a hugely horrific case of torture and homicide of her two adoptive sisters. And it was at that moment or around this case that I began to realize how these patients affect us directly, and how we still have to do our job through that. We have to push through it to continue to do our job, but that doesn't mean we are unaffected. And so, certainly as a child abuse pediatrician and those of us who work in the child abuse arena, we hear traumatic disclosures, so hearing the stories of what has happened, seeing the injuries themselves, both the kind of morbidity and the mortality, certainly the children who unfortunately pass away as a result of their injuries. Managing the emotion of parents in the context of evaluating a child for abuse. Managing the emotions of coworkers who often want to debrief as you're trying to evaluate the patient. Managing your own emotions. And then on top of that, the need for timely and meticulous history taking and documentation. More chronically for child abuse pediatricians, that's like the acute scenario around evaluating a patient. But as you might imagine, the parents are not always our allies, as they might be in other areas of medicine. There is often opposition to our assessments, and the risk, although I cannot personally say I have ever experienced threats to my personal safety, but certainly the risk is there. Complaints to an employer because of the dissatisfaction in your assessment, negative media. Certainly child abuse pediatricians have been, their names have been thrown out there in well-respected periodicals, retaliatory malpractice lawsuits, which technically are not legal, and there's some legislation that does protect child abuse pediatricians to some extent, but not fully. And there are efforts to improve that. Certainly complaints filed with professional licensing boards. And then the recurrent vetting of credentials by parents and in the courtroom, where you have to prove at every encounter that you are have the qualifications to say what it is that you're saying. And then I think this is a frustration that many of us share working in a system that doesn't always respond how we want it to respond, despite best efforts at doing what we should and can do for patients. And I could, have a very fatalistic perspective, but what I really, I think, have come to realize is that, if I look at it that way, it's not sustainable. If I look at just the difficulties and challenges, it's not sustainable. And the question is, how do you then sustain yourself in order to continue doing the work? And, you really cannot pour from an empty cup. You cannot express compassion at the same time being, clinically astute and meticulous, et cetera, if you are completely empty and exhausted. And so taking care of yourself first, is important. And this is not limited, of course, to child abuse pediatricians. It really applies to all of us. So I'm gonna go through just a few definitions this morning because there's a lot of conversation in healthcare about burnout and the effects of burnout and the risks of burnout and many efforts to mitigate that. And I just want to be clear about what we're talking about this morning. And so there's burnout, there's secondary trauma, and vicarious trauma or compassion fatigue. Burnout really is a result of three things: mental and physical exhaustion, indifference and cynicism, and a sense of low personal and professional accomplishment. Those are the three elements that characterize burnout. And it is truly the result from chronic exposure to high levels of occupational stress. And I think we can all say that we have experienced occupational stress at some point in time. The question is the chronicity of that and how it's manifesting with you. So if you want to take out your devices, if you're logged in, and again, there we go. Oh, okay. That is pretty striking, and let's see, okay, that's a little bit better. We don't have a huge crowd, so there are about 29 of us here on the call. Okay, good. And so maybe those of us in category A can learn a little from those of us in category C, or maybe even more so those in category B who may have experienced burnout but are now on the other side of that. Thank you. I'm trying to advance all these technical issues here. Oh gosh. Sorry, guys. I'm going to escape for a second. Bear with me for a moment because for some reason it doesn't want to cooperate. Okay. So, oh goodness. Let's try. Okay, there we go. So the Medscape National Physician Burnout and Depression Report, the most recent from 2019, is a survey of over 15,000 physicians across the country. And they survey on a host of elements. And this is just one that of the results that I wanted to share with regard to which physicians are the most burned out. And I apologize for not having like nursing related data on the same subject. But as you can see, pediatrics falls really right kind of within that mid group with about 41% reporting feeling burned out. Emergency medicine is up at 48%. The urology, I don't know what that's about, but 54%. Curious to know why that's so high. And you know, those who are working on the health of the larger public, 28%. So go figure, not sure what that's about either. I think what is, you know, to have that information, you know, some may say, well, you know, so what? You know, it's a rough career, and you kind of have to accept that that's the fallout from it. But the outcomes can be pretty severe. And even in the midst of this COVID, there was I heard on the news last week, a physician who did commit suicide. Certainly, suicidality is prevalent among healthcare professionals. Here in this survey, 14% of the participants have had thoughts of suicide and 1% attempted.
Dr. Jackson?
Yeah.
We did have a question through the chat
Yes.
about the urologists.
Yes.
Do urologists ever treat the effects of like sexual abuse? Are they ever involved?
Not at Children's, not that I have ever heard. Not that they couldn't be, but I have not ever had a need to consult urology.
Okay, yeah, it's just there's lots of comments through the chat of like what's going on with urology, and maybe that's the thing. So
I don't know. We need to talk to them. And I would imagine that those are not pediatric urologists. I have a feeling, but I don't know. It could be cancer-related treatment. I don't know, though. It's a good question.
thank you. That's the only question so far.
Okay, great. So, the follow-up is, well, what is this secondary trauma thing? Okay, we got the burnout thing, and there's, lots of literature about burnout, and, the hospital is doing all these things to try and help mitigate burnout. But what is this secondary trauma thing? And it's something that I think we talk much less about. And the definition of secondary trauma is right here. Natural stress-related consequences that result from knowing about or witnessing a traumatic event experienced by someone else. It is immediate and can mirror the patient's trauma. So, for example, with my patient scenario that I shared earlier, that feeling and the response that I had to her, the dreams that I had about her, and the immediate aftermath of evaluating her could constitute a secondary traumatic response. So you only need like one bad situation to experience secondary trauma. So, for those of us who shared, which would be pretty much all of us who are adults, the 9/11 experience, the secondary trauma of that experience, one day's worth of events, certainly could result in secondary trauma for any of us. It keeps wanting to jump to something that I don't want it to jump to, but let's see if you can answer that. So reflecting, I have been emotionally affected by my patient's traumatic experiences. Yeah, so I think this is pretty common. And, when we think about the fact that hopefully we are compassionate people and that we feel some level of connection to our patients, that there may, if we have been involved in the care of patients who have experienced something traumatic, that it is not surprising that the majority of folk have had some kind of emotional impact from that. And to be unsure, I think, is also like to be ambivalent. And we'll talk a little bit about coping and how we cope and, why it may feel more vague or ambivalent about how you may or may not have been affected by a patient. So the last definition is compassion fatigue. Kind of what is that? And compassion fatigue really is a cumulative effect. So it's not the one case, it's the many cases and the effect that that has. And so for those who work regularly with patients or families who've experienced traumatic events, those are the individuals who are susceptible to vicarious trauma. And certainly any of us who care for sick individuals on a regular basis can experience compassion fatigue. I just wanted to briefly share this. So the Office of Victim of Crime, which is a federal office, has a vicarious trauma toolkit. And the reason that I put this on here, the victim service community, and what I mean by that are, the professionals who work in victim service fields, whether it's domestic violence, sexual assault, child abuse, community violence. Those professionals know very well about vicarious trauma, and they are often engaged with the Office of Victim of Crime in some way, whether it's grant funding or something along those lines. However, healthcare professionals have been deafeningly absent from this conversation. We like to talk about burnout, but we don't talk about this quite so much. And there are resources. This toolkit is actually, I think, most helpful at the organizational level as opposed to the individual level, though it might certainly be informative for an individual. And so I think in the healthcare field, we still have a long ways to go as it relates to understanding, acknowledging, and mitigating the effects of vicarious trauma. So how does this look for any one of us? And you might think about a certain diagnosis as you begin to see some of these symptoms or signs. So hyperarousal symptoms, nightmares, trouble concentrating, sleep difficulties, repeated thoughts or images regarding the traumatic events or what you've seen on your patient. And not, you may not even be trying to think about it, but it's still kind of coming into your mind, your thoughts, feeling numb, unable to tolerate strong emotions, like you just can't handle that, increased sensitivity to violence, feeling generally just a sense of despair or hopelessness, loss of idealism. Many of us go into healthcare fields to change the world, right? We come into this arena ready to take it all on, and we may feel as if we've lost that, or may in fact have lost that sense of idealism. Guilt regarding your own survival or pleasure, like I shouldn't be feeling this way, I shouldn't, people have it so bad, I feel bad that I don't have it that bad. Cynicism, anger, disgust, and fear. Does anyone want to put in the chat what diagnosis this makes them think of? See if I can. Yes. PTSD. That's it. That is the one. So we don't really tend to think that our jobs can cause us to experience PTSD, certainly not in healthcare, although these days maybe that's going to be the new normal. So some other ways that this might manifest is difficulty setting boundaries, separating work from personal life. So that comment that I made to my husband about, well, maybe we can adopt her, we can, take her home and we can raise her. That was a boundary problem. And my boundary is to do my job as well as possible and allow others to participate in the caregiving in that sense. Feeling like you never have any time or energy for yourself, disconnected from loved ones, increased conflict with relationships. This one is really striking to me. The silence response. So if someone else is distressed, that you really can't be attentive to listening to them. You're just too overwhelmed, and you just want to talk about, like, I don't know, anything, the weather, something benign, and not deal with anything that's too heavy. Social withdrawal, decreased interest in activities that bring pleasure, being irritable, intolerant, impatient, needy, or moody. And then even dependencies on nicotine. I need to go have a glass of wine or something harder. Eating, sex, internet, kind of compulsive use, shopping, and other substances. Even sexual difficulties and general impulsivity. So, what jumps out at me when I reflect on some of the things on this particular list are depression, anxiety related concerns, or even a diagnosis of anxiety disorder. So the mental health impact of these experiences is not to be minimized. So the question is, how do we manage? Because we are bound to experience patients who've been through something difficult. And so how do we manage? How do you manage? And this is a, kind of a reflective thing. This is a wheel or concentric circles that give some examples of how one copes. And sometimes those mechanisms of coping are positive and sometimes negative. In medicine, I think many of us use kind of intellectualization as a coping mechanism. We become very scientific, which is a good thing and an important and needed thing. But that is just how we manage. We just, don't want to get into the emotionality of it. We just want, what's the logistic regression and all of that kind of thing. And then there are others who may, find other means of coping, whether it's mindfulness or getting enough sleep or writing in a journal or finding humor in other things. And sometimes I have to say we do find humor in ways that maybe are humorous within our circle, our professional circle, which may not be appropriately humorous anywhere else. And I think we have to be cautious about that when it comes to trauma, particularly because abuse, assault is common, and no one really knows whether or not you have a coworker who has ever experienced some of those things, or a student, a medical student or trainee, nursing student, etc., who has personally experienced some form of trauma that is similar or victimization. And so we just need to be mindful of the humor that we invoke to cope. So, are we all equally susceptible to vicarious trauma and compassion fatigue? And the answer is no. And that certainly can explain why some people have the capacity to do certain jobs and that others might not feel they have the capacity or know that they don't have the capacity to do. We are all kind of designed and have experiences that allow us to either do something or advise us not to do it. And I think these are some of the elements, and there's some things that are beyond our control, and there are some things that we can control. So there are individual factors, there's the level of exposure, and then there are organizational factors that all play a part in whether or not we develop secondary or vicarious trauma, and then how that affects us as a whole person. So the things that increase the risk are having a high volume of exposure. So being in fields or areas where you're going to see a lot of this. So working in the child abuse arena, working in the emergency department, working in the PICU, those kinds of settings, being a part of a trauma team, response team will certainly place you at greater risk for experiencing vicarious trauma. How much support you have if you are working in those kinds of settings, or even if you're not. Again, it can take one case to affect someone. The level of social isolation. So I have colleagues in the country who are like the one child abuse pediatrician in their hospital, or maybe two child abuse pediatricians in, the region. How they manage to do that is beyond me, but it is very socially isolating. And then, of course, there are individuals who do the work, but who are isolated at home. And so, yeah, they may work within a team, but there's no social supports beyond the workplace, or limited social supports beyond the workplace. Certainly folk who are younger can be at increased risk, or those who have less experience in that particular job. And then again, having a personal trauma history. And it's important, again, statistically, odds are that there are many people who work at Children's Hospital, many people who are healthcare professionals of any kind who have a personal trauma history. The statistics are such that we know that will be true. It is important, if that is the case, that those individuals make sure that they are attentive to their mental health needs as it relates to the trauma that they experienced in the past. So there's the risk, but then there's also resilience. And the question is, do you have the ability to reflect, the opportunities to reflect? Are there opportunities for emotional and intellectual closure to your involvement, engagement in these traumatic experiences of others? If you have adequate staffing, then is there the capacity to share the load, share the burden, so to speak? So here's another question for you. I have figured out how to manage the stress of patient care in a healthy way. So we're about a 50-50 yes and a maybe. So I am not participating in the poll, but I would say I am still a work in progress. So I probably would be the maybe as well. And some days I'm maybe a yes, and other days I'm not quite so good. So thank you for sharing. Okay, one more here. My workplace is mindful of my well-being. And here are the responses. Yes, there are concrete ways well-being is being promoted. Yes, but there's nothing concrete. No, not sure. And so not knowing necessarily the workspaces of, everyone who's attending this morning, if you're in the no or not sure categories, maybe there is an opportunity for you to be a champion for this in your area. So I, don't want to leave you all thinking that this is all bad and, we're all doomed to have PTSD and we'll all need psychiatric hospitalizations. That is not true. It is not all bad. There is something called vicarious resilience and vicarious transformation. And so we can turn our experiences with patients into something that strengthens us and gives us the fortitude to push through and maybe do something different or do something more. And so we can be inspired by those very patients. So that little girl who told me so many horrific things about the abuse that she experienced, and her body itself told a story that supported the words that she shared with me. But this little 8 or 9-year-old girl, and I'm a little ambivalent about her age because she was ambivalent about her age, was able to testify in court against who she called her ex-mom. She was an absolutely amazing little girl who, despite the horror, was able to survive. She got out. Like, who does that at 8 or 9? And to be inspired by an 8 or 9-year-old, really, I think for me was what I carried away from that experience. There's also satisfaction in the compassion that we express to people when they're going through difficult times. And I would imagine people who do palliative care might really experience something similar, certainly those in the ICU, hem-onc, who deal with end-of-life issues on a regular basis, and those who work with survivors of abuse and assault may tell you that for them it is actually a privilege to be a part of difficult moments with families. This is not for everyone, that's for sure. But that there is some sense of meaning of being able to respond to people in crisis. And of this survey of child protection staff in Colorado, 50% of them experience high levels of compassion fatigue, but that means that the other 50% did not. And so there is a sense of meaning and value in the work that we do. So, what can you do to make this manageable? And I think this applies not just to compassion fatigue, vicarious trauma, or even burnout for that matter. These are strategies for your own well-being, period, I think. Of course, good health practices of eating well, sleeping well, and getting enough exercise, enjoying your hobbies and families, friends, and faith community. And now we're doing it virtually, but still not, isolating yourself is important. Recognizing, accepting your limitations. We are not machines. And when we become like machines, then I think we probably need to be doing something else. And then take advantage of formal therapeutic interventions. If we feel comfortable enough saying and recommending mental health services for other people, then we need to be able to accept that maybe there are times in our lives that we would benefit from that as well. The EAP program at the hospital is something that every employee is eligible to receive confidential support. I think there are about 6 free sessions that are available, but you could find that in human resources. You may need and benefit from individual psychotherapy or group support. And then there's some other things to contemplate. So every now and then we learn that the job that we're in is not the right job for us, or that it is no longer. It was great for a season and now it is time to move on to something different. Sharing your thoughts with your coworkers, talk about it amongst yourselves, being mindful of HIPAA in the process. Learn about stress and coping, maintain realistic goals, set boundaries, and be mindful of when you might be crossing those boundaries with your patients and families. Having a time of reflection after exposure. If you could just go, you have a difficult situation, you have to do your responsibilities in your capacity as a healthcare provider in the immediate, but if you have to just go walk through the healing garden for a minute, then do that. Self-monitoring, assessing your own reaction and behavior changes. Journaling, some people love to write, or drawing, or music, whatever it is. Focus on what you did right and not what you missed, could have done, etc. And then there are some other modalities that people find helpful, whether it's prayer, meditation, or mindfulness. On the professional side, as an individual, I think the opportunity to work within a team of professionals from different areas is certainly beneficial, where the burden of care doesn't all fall on one person, and that you make use of the expertise of those on your team to the benefit of the patient and to the well-being of the staff. Turn your passion into power. So use those experiences. You may find that you really care about something, and now you're going to kind of use your non-clinical efforts to focus on that issue. I have personally found that particularly helpful, and I continue to learn from my patients and use what they have taught me to then advocate and do other things. Use your leave. Leave work at work, which is, I know, difficult, as we can now Zoom anywhere, as we can do charting anywhere. But, there's some places in your home that you just need to keep sacred. Don't bring that stuff in your bedroom. Keep your work in a special place in your household, and don't let it permeate all aspects of your life. And then look out for your coworkers. At the organizational level, it's interesting because I have been told in the past, we're not even sure that this really exists when it comes to secondary trauma or vicarious trauma in particular. And so we want to make sure at the organizational leadership levels that there is an understanding and acceptance that these things are real. They are not made up. They are not complaining and whining. It is a risk as a result of the exposure to trauma. So just as we have preventative efforts to mitigate the risk of certain infectious diseases, whether it's through PPE, whether it's through immunizations that are required in order to work in a healthcare setting. Similarly, we need to have preventative efforts to combat the effects of repeated exposure to trauma and the tragedy of others. And that means that at the hospital leadership level, optimizing workforce capacity and responding proactively to that workforce is so critical. The National Child Traumatic Stress Network has some great information around vicarious trauma, and they have some strategies for prevention, many of which, I've shared with you this morning, and then some strategies for intervention, whether or not they are kind of specific kind of mental health interventions or more kind of mindfulness or structural interventions within a healthcare setting. So I encourage you all to, if you have something to write on and to write with on a piece of paper, if you could just write down one organizational or agency or individual, or you can have more than one, strategy that you want to try. And I'm going to go back a slide so that you can see the list of suggestions here. I'll give you a couple of minutes. If you want to share any thoughts on that in the chat box, you can certainly do that as well. I'm looking at a comment, something I've noticed in my peers. I can admit to myself the numbing after a trauma or loss. Is there something you recommend to balance the numbness needed to do our job and go back to the unit after a loss versus staying in touch with patients and families and having empathy? You know, we do in many ways have to compartmentalize because of the nature of our work and our roles with patient care. And, you know, in the moment you may be seeing this awful thing and having to intervene and having to give bad news and all of that. And you may be on kind of automatic in that moment. And then you have that opportunity. Hopefully you give yourself that opportunity when you are able to get a break or to ask for a break if one is not given to you. And that's, you know, maybe someone should be suggesting, you know what, one should go take a, 10-minute break. Just to kind of recenter yourself. And, you know, in a busy emergency department, that may not necessarily be realistic within a chat, you know, and maybe that's something within the emergency department that there could be conversations about how you manage that. And this is separate from the debriefing that I know often happens in certain settings, which I think is critically valuable. To debrief, not just about the technical and medical aspects of what happened with the patient, but also around how folk are doing. I know the chaplain, the hospital chaplain is certainly willing to participate in conversations like those. You know, in terms of reaching out to family members or connecting with family members who have experienced a tragedy. I know some people will go to a funeral. There is absolutely nothing wrong with that. I think that is a level of compassion that means so much to families. And I have had families say, you know, we knew that you loved, you know, fill in the blank of the patient. I had a family member share that to me after I testified in court. And so there's nothing wrong with that at all. You just have to be mindful of how much that takes over, and whether or not you're able to put some limits around that. And then someone commented about the Mindful Mentor Program here at the hospital. And then there is also, if you want to kind of do a personal self-assessment, this website here, ProQual, is a website that has a survey that you can score, and it's something that you could do, you know, twice a year, once a year, just as a personal check-in on how your work is affecting your quality of life. And there are also some resources on the intranet, the provider wellness program. You know, there's even more available, I think, now. I know Aetna, I think we received some notification about Aetna offering support through this COVID crisis. But certainly there are things that are happening in our institution and are available in our institution that I encourage folks to take advantage of. And I have a feeling that this is probably not going to work. But this was going to be a moment of mindfulness from a YouTube site, because I am not a mindfulness guide by any stretch of the imagination. But if you want to just take these 5 minutes or 4 remaining minutes just to take a pause, you know, reflect on why you do what you do, or just take a moment just to breathe before you start your day, or for those who might be ending their day, ending your day. And I thank you for joining today. Take care of yourselves, everyone, and please, please stay tuned for upcoming lectures that will be in this series. Please complete your evaluations and be well.